Thank you, Raul, very much. It's very much my pleasure. It's very much my pleasure and honor to be here and be able to share with you in a brief moment, which is only just a few minutes, 50 years experience.
En un breve momento, en unos pocos minutos, le mostraré la experiencia de más de 50 años.
In 1963, November 22nd, which was 57 years and 2 days ago, President Kennedy and Mrs. Kennedy were arriving at the airport in Dallas, and behind him was the governor and his wife. And they were here on a visit. They were here in Dallas, and they had a parade. And in that parade, something happened.
President's car is now turning onto Elm Street, and it will be only a matter of minutes before he arrives at the straight mark. It appears as though something has happened in the motorcade route. Something, I repeat, has happened in the motorcade route.
3 shots rang out, and 2 minutes later, they were bringing President Kennedy and Mrs. Kennedy to the emergency room at Parkland Hospital, which was only 2 minutes down the road. And we knew if there was a problem that the president would be brought there. It was in a small trauma room number 1 that I entered this room, and there was my hero, the president, lying on the table with the right side of his cranium blown off, an open brain, and a sucking wound of his neck. At the top of the table, when I entered the room, was Jim Carrico, Dr. Carrico, one of my colleagues, and on the left-hand side of the gurney was Malcolm Perry. I proceeded to take my position on the right-hand side of the gurney, and we were trying to intubate the patient and couldn't, so Dr. Perry says, let's do a tracheostomy. So we did a tracheostomy and put an endotracheal tube in, did everything we could over a 30-minute period, but could not resuscitate this famous young president of the United States. So I was on neurosurgery, a first-year resident at age 27. And my chief was Kemp Clark of neurosurgery at that time, and he pronounced the president. Everyone left the room, and I stood there, I guess at that moment, was in shock. And Jacqueline Kennedy came over and had blood splattered on her pink outfit. And she took the hand of the president and did a ring ceremony as I witnessed. I simply did not talk to her. I nodded, and she was obviously in shock herself. On the autopsy table, when they took the president back to Washington, D.C., this is how he looked, but they sutured up this open wound here on his skull so you don't see it. But here's the tracheostomy incision that we made trying to save his life. But at the time I undressed him, why, he had this large corset on, and I was surprised to take this off, and also his shirt, which was bloodied, and you can see the entrance wound of one of the bullets that entered the back of his neck and went throughout his trachea. So what happened was this: he had the brace on, and this was the pivotal moment in history, because without the brace, with the shot in the neck, it would have come out through the trachea and it would have knocked him over into the front of the car, and there would not have been another shot. However, with the brace on, it held him up in position. It went through the seat, knocked the governor down on the floor, and he was still upright, leaning over towards Jacqueline Kennedy. And the second shot hit him, going back into the back of the head and exploding out the right side of his skull. The world was in mourning, and after this tragic, very tragic moment in history. But for me, it was a defining moment. And as one of many John F. Kennedy's quotes, for the final analysis, our most basic common link is that we all inhabit this small planet. We all breathe the same air. We all cherish our children's futures, and we are all mortal. And believe me, the years passed by rapidly. I don't know how I got to be 84 years old, but it happened very quickly. But for me, it was a defining moment because the president had founded the Peace Corps. And this, I didn't know at this time I was going to even be a plastic surgeon. But I went on to become a plastic surgeon, and I trained with David W. Robinson, who was an excellent surgeon at the University of Kansas and had one of the leading programs at that time. And I had seen him as a medical student doing a cleft lip, and I was totally fascinated by this operation. And so I learned good cleft surgery, which was for the state of the art in 1969. But I had never seen craniofacial surgery or even knew at that moment that it was going to play a significant role in my life. And so the majority of the patients that I treated in my whole 50 years were craniofacial and cleft deformities. I was on a Earl Pageant traveling fellowship and went to NYU and met Dr. John Converse. And I went into the operating room, and there he was doing a case I had never seen or knew nothing about. He was doing intracranial craniofacial surgery. He later on, of course, Sir Harold Gillies did the first Lefort 3, and he said this operation should never be performed again. But along came Tessier, who saw that patient, and he electrified the world when he introduced at the Confederation of Plastic Surgery in Rome in 1967, his cases that he had done. This was the first patient that he ever performed intracranial facial advancement. In 1969, as a young man, I went back to Texas and became the first professor of plastic surgery. I first was an assistant and worked my way up to a full professor, and I started a plastic surgery training program which reached national notoriety. Here I was as a young professor in the laboratory, and I did a lot of research at that time, but I was interested in craniofacial surgery because of Dr. Converse. He introduced me to Tessier, and Tessier invited me to Hospital Foch in 1972 in the spring. And here he was demonstrated for a week, some 20-some doctors. But I met a special group of doctors, and the previous speaker, Kamala Monegro, frequently mentioned Fernando Ortiz Monasterio, and I'm sure all of you know how famous he was for all of Latin America and had the most outstanding training program in Mexico City. This was Ian Jackson from Canisburn at that time, Scotland, Ian Monroe from Sick Kids Hospital in Toronto, Daniel Marshak from Paris, Linton Whitaker from the University of Pennsylvania, and I don't know who this fellow is with that plaid jacket on. We all became the best of friends and formed the International Craniofacial Club, and we traveled the world together, and we challenged one another, and we learned from one another, and we made an exciting adventure of craniofacial surgery. Paul Tessier never did any infant craniofacial surgery. This group of men introduced craniofacial surgery in infancy. This was the last time we were together. Ian was off sailing around the world, Monroe. But here are the five of us, the last time, June of 2012. And that same year, Fernando and Daniel Marshak passed away. We all went home and developed surgery ourselves. We saw Tessier for a week. We went home and started in the cadaver lab and working, and soon started doing craniofacial surgery, teaching ourselves. But we promoted the multidisciplinary team approach. Here's an infant case that I started doing in the early 70s. And this was a technique of Daniel Marshak, the floating forehead. And the only report that the 6 of us ever did was this one combined report of all of our cases. We started in the early 70s, and 79 reported on 793 cases. But our complication rate was 35%. Obviously, with more experience, we gained how to do it with fewer and fewer complications. But in the process, I was able to do a total craniovault where I can change the vertical height, the anterior shape, and the posterior shape and projection of the skull in one operation without increased morbidity. The 4 of us here wrote the first atlas. We called it Cranio-Maxillofacial Surgery and published in 1982. This was a picture of our travel club that we started in 1973. But together, we popularized and developed infant craniofacial surgery. We expanded craniofacial surgery. We were the original founders of the International Craniofacial Society, and we added a few other members to join with us. But it was our idea to do that. When we first met, we went around to different places. And when we were in Mexico City, years before the foundation, before the International Society was founded, why we decided that was something we wanted to do. We each received many major awards, and together, we published over 1,000 scientific articles, and we trained over 250 fellows. And as you know, Fernando Ortiz Monasterio trained 800 residents. In 1986, we founded the International Craniofacial Institute. And I was able to recruit Derek Bruce and one of my band of brothers, I call them band of brothers, Ian Monroe from Toronto. And we developed a premier center where we treated patients from every state in the US and 75 countries. And our complication rate went way down. And so I was fortunate enough to develop this dream team and had struggled prior to that time in developing a really world-class team. And so we had all of these representatives on our team as a full-time endeavor, which allowed us to develop and expand our horizon. I did over 16,000 operations from 1969 to 2006. And each craniofacial and cleft lip and palate were over 5,000 procedures, and there were another 5,000. During that time, we developed many new techniques, and we started using more split craniobone, and we developed plate and screw use, and we developed some other advances that I'll show you in a moment. But one of the important things was the development of facial cranial surgery, where we gave the neurosurgeons a new exposure for removing large tumors of the cranial base. It was in 1989 that I founded the World Craniofacial Foundation, and now it's 31 years old. And we have trained many fellows. We made our first trip to Taiwan. I took this team from Dallas, and we did the first craniofacial surgery in Taiwan. And my assistants were Fu Chong Wei and Ray Chen. when I did the surgery, and my neurosurgeon didn't show up, so I did my own neurosurgery, and we did eight cases. And Ray Chin decided he wanted to do craniofacial, and he became my first fellow in 1979 and spent a year in Dallas with me. Here we are in 2013 celebrating, going back, and we went back to Taiwan many times, and Taiwan has served as our model for developing other centers around the world. They today are world renowned themselves, thanks to Sam Nordoff, whom I'm sure many of you have heard of because of the clefting pioneering work, and he became superintendent of the hospital, and because of the richest man in Taipei, developed a world-class center. Craniosynostosis is one of the areas where we spend a lot of time operating and doing hundreds and hundreds of cases. The complex cases are the syndromal cases. And this is a algorithm of my approach starting back in 1973. And I started operating on them at the same age I was operating clefts, and the relapse was at least 20%, 10 to 20% of the relapses. So we started 6 months as the ideal age to do major remodeling of the cranium, and that has been used ever since that time. And it's when we started doing posterior cranial vault remodeling in 76 and total cranial vault in 86 when Dr. Bruce joined us and Ken Shapiro, and we started doing more major total cranial vault remodeling in one operation and doing it safely. The workhorse for, in addition to infant remodeling is the Lefort 3. And then later on, the monoblock distraction became a safe procedure that I performed frequently around the world safely with our dedicated world craniofacial team. The Lefort 3 is the workhorse, and here is the very first Lefort 3 that I performed in 74, and then followed up with a rhinoplasty and a sliding genioplasty. And her occlusion was treated by Dr. Jenico after we did the advancement, 17 millimeters on one side and 14 on the other. The indications for cranial vault remodeling are closed sutures, abnormal skull growth and shape, increased intracranial pressure, of course, particularly in these syndromal patients, severe exorbitism, or aesthetic contour in older patients. This is a case I did at Children's Medical Center in Dallas in the 70s, was a 2.5 centimeter monoblock advancement, successful with a tongue reduction. What happened? He didn't ever come back, and this is typical for syndromal patients. Here's how he looked when he came back. This is an oblique view. And you can see we've made a big improvement in this young man's appearance and function of his mouth and teeth. And here he is, 17 years later, having had no treatment. These patients require repeated operations until they're fully grown to get a good functional and aesthetic result. And people call this relapse, and it's not relapse, it's abnormal growth. They're programmed genetically to grow abnormally. We modified the monoblock advancement because it had so many infections. Fernando Ortiz told me about first doing the monoblock, and before he published it, 2 years before he published it, I went home and did 4, and 3 of them got infected. This is another monoblock patient that came to me from India, and I did a 1-stage monoblock advancement with no complications. But I rarely did the monoblock because of having those first 3 infected cases. And so when distraction came along, like particularly in treating sleep apnea, like in this boy from Argentina, that we did about 10 years ago with Diego Steinberg, who is one of our medical directors of our foundation, of the World Craniofacial Foundation today, but also was a fellow in Dallas training under the auspices of the foundation. So 3D modeling and being able to cut the model ahead of time and form positioning of the distraction devices and doing distraction, monoblock distraction allowed us, we modified Fernando's procedure and made it so that we could do this in 2 parts anteriorly, and that gives us better access for cutting the full face and advancing it. Here is this boy 60 days later with his distraction units in place, and we've eliminated his apnea. When we've all first started doing this work, the first operations we did, we simply mimicked Tessier. And one of the classic operations he did was the hypertelorism. Now, many of you probably don't know, Tessier did it in 2 stages. Converse introduced the 1-stage operation, which then we all started doing. And it was van der Meulen who did the facial bipartition. He gets credit for doing facial bipartition. And of course, Fernando Ortiz Monasterio gets credit for first doing monoblock advancement. This was the first case I did in September of 1972, and my goal was not to have any incisions on the face. This was a little Robineau case, less than 5 feet tall, and I went to her wedding, and her husband was 6'2", and it was a wonderful special occasion. So my case experience was well over 200 cases, with each case requiring to get optimal result 3.75 operations. The biggest complication was extraocular muscle abnormality and secondary lacrimal problems. But in general, we had no deaths and no one eye with decreased vision out of 200 cases. Here's a typical case before and after, and we learned from Tessier we can elongate the nose using a bone graft. Here is a picture, CT and MR, and here is a morph before and after. This boy was went back and got a master's degree and became a counsel for addicted drug patients. He was a foundation patient. Here's a lateral view, and you can see how you can nicely, in one procedure, lengthen the soft tissue with a bone graft. This was a difficult case I did in the 70s, and it was a traumatic result in this boy who's leading a normal life. This boy came from Guatemala, along with another patient that we did under the foundation. And the encephalocele patients are not hypertelorism. They do not have true hypertelorism, but they tend to have a long nose. But what I learned was that by lowering the bando, we can then create the illusion of not a long nose. And this boy was done in 5.5 hours at Children's Medical Center with a beautiful correction, and long-term follow-up did not need additional grafting. Now, one of the major contributions is in trauma and in tumors. And a major contribution has been craniofacial surgery because of the cranial-based surgery. And as I mentioned earlier, we can do facial cranial surgery and give the neurosurgeon dismember at different levels the face and allow removal of major tumors that could not be done before. And these techniques were developed in Dallas. Here's a patient with fibrous dysplasia, and I treated over 100 patients with fibrous dysplasia, and many of them have compromising of their optic canals and develop, the first sign of that is the development of colored vision goes away. And this girl had an optic nerve decompression at the same time that we did a total reconstruction of her entire orbit. The tumor is extensive and you can't remove all the tumor, but we did in the orbital region. And a lot of times this does not go ahead and progress. This is the reconstruction, removal of the tumor, a split cranial bone using her own bone, and reconstruction of her orbit. This is in the operating room. And we can see the use of titanium plates and screws. Here she is after surgery. And as far as I know, she went on, I followed her for 10 or 12 years without needing any further surgery. Here is a case that came to us from the Mercy ships. It's a juvenile ossifying fibroma. And this entire area was totally resected. And the single seeing eye was translocated with a hypertelorism, a monohypertelorism translocation of the orbit. And this patient I thought I'd gone to another planet when I looked at this tumor. It totally occupied the anterior craniofossa. We removed it totally. And one of my fellows said, oh, you have to do a free flap. I didn't do a free flap. And in spite of this dead space, it filled in. And here is the reconstruction with cranial bone. You can see her. She did get a small infection in the temporal area, but otherwise did very well. And we were able to return her to her home in Africa after some time of rehabilitation. Now, one of the major advancements during my 50 years is preoperative planning using 3D CT and MRI models. When we started, we did not have CTs, we did not have MRI, and today we can do virtual surgical planning and do this any place around the world. I can sit in Dallas or in Telluride or elsewhere and plan this surgery and do teaching using this with teleconferencing. It's quite impressive. And innovation in planning and education, the virtual planning, the global video conferencing is really a major advancement. Now, in closing, I want to present one more case. Now, Dr. Barcelo is another one of our fellows in craniofacial surgery and is also one of our medical directors. And he played a significant part in the separation of these twins, as did 50 other members. This was a major team effort, and we did a lot of new innovative things. With the beautiful, extensive development of three-dimensional technology based on CT and MRI data, we're able today to look inside and outside of the head and brain and look at all of the little structures and their relationships very, very accurately. We created three-dimensional reproductions of the boys' entire bodies, and we can actually do a anatomic dissection, if you will.
We did feel somewhat responsible in this case and had prominent members of the surgical team say that the models were the most important piece of information they had. And if something went wrong based on what we had shown in the model, it could well mean death.
We had those models in our hand as we did the surgery and the reconstruction, and they were very helpful. The other thing that was helpful is that with KCI, we developed a $500,000 bed. And we're going to use this again in another set of twins that we're going to be involved in with Chris Gordon, another one of our medical directors of the foundation in Ohio. But this really was a major advance. It had never been used before. And instead of the surgeon having to stand upside down. We also, after we separated them, they just had soft tissue closure of their skulls. And then we came back a year later and developed this resorbable lattice work with demineralized bone and bone morphogenic protein. and they totally regenerated their skulls. So they had totally replaced their skulls as well as the good. And the planning that Dr. Barcelo involved was planning so that their hairline was good and their hairline was normal, as well as the flaps that he designed. So the challenge for the future and for now has been, what does the progress mean if it's only available for a minority of the world's population? So I've spent 31 years trying to establish centers along with my other medical directors, and more recently, Rolando Prada has become one of our medical directors too for the foundation, and is doing wonderful work in Colombia and in Bogota, and we're working together to see that more patients are treated. When we started in Dallas, and I worked very closely with Fernando Ortiz Monasterio, and we helped support anesthesiologist there where he could do more cases along with Fernando Molina, and that was a good project. I also went to Puerto Rico and did the first craniofacial surgery in early 70s. Then over time, we visited other places around the world trying to develop additional teams or supporting ongoing teams. And these are all of the countries that we have touched one way or another. We were working in a wonderful center in Libya with another one of our former fellows, Akira Yamada, and the hospital we're working in were blown away with the revolution. Of course, Taiwan has become a showcase, and now Philippines also, which is a spin-off of a center that we developed there along with Dr. Nordoff. So we've made a lot of progress in what we've done and where we've gone. And possessing a face you aren't forced to hide is a fundamental human right, as important to a fully lived life as freedom from fear or want. Thank you very much. I appreciate it.